of median arcuate ligament syndrome. Hope you are able to see the second slide now.
It's just the first slide that's going on.
Okay.
Okay, that's fine.
So the median arcuate ligament syndrome, it's also known as celiac artery compression syndrome or Dunbar syndrome, and it is basically anatomic and clinical illness which is resulting from an extrinsic compression on the celiac axis. So we have to know about the basic anatomy, how it is getting compressed. The anatomy is there is two right and left diaphragmatic crura. The fibrous edge of the diaphragmatic crura pass anteriorly and medialward, meeting in the midline, which forms an arch. And this arch across the front of the aorta, which is called median arcuate ligament. It is at the level of the celiac artery. Usually, the arch is often poorly defined, and the area behind this arch is known as aortic hiatus. And the celiac nerve plexus branches across the abdominal aorta between the vertebral level T11 to L1. So in the next slide, you can see that picture showing normal median arcuate ligament with celiac artery, and that median arcuate ligament which is compressing on the celiac artery is seen on both sides. The celiac nerve plexus branches across the abdominal aorta between the vertebral level T11 to L1. So you can see that celiac artery and ganglion here, and the branches of the celiac nerve plexus also. So this is the median arcuate ligament which is seen compressing the celiac artery. So majority does not encroach on celiac artery. In majority of the cases, it does not encroach upon the celiac artery, and there is no compression at all. So in 10 to 24% of the population, the median arcuate ligament compression occurs, but they don't have any symptoms. But in less than 1% patient, they are symptomatic. Those symptoms are mainly postprandial and exercise-induced epigastric abdominal pain. They have nausea associated with it, vomiting, gastric dysmotilities, and weight loss, and a food fear or fear of pain triggered by eating. So coming to the pathophysiology of the pain, that epigastric pain caused in median arcuate ligament syndrome. So there are various theories for this pathophysiology of the pain. First one is that there is an increased blood demand through a compressed celiac artery, and which causes foregut ischemia and pain. But the thing is that there is collateral blood flow between the mesenteric vessels, which compensates for the subtotal or intermittent occlusion of the celiac artery. And also that other various tests like gastric exercise tonometry, gastric perfusion studies, etc. documents that mucosal oxygen delivery does not correlate with celiac artery compression or its clinical symptoms. And endoscopy has never reported a cause of gastric necrosis or gastric ischemia due to median arcuate ligament compression. So the second theory is midgut ischemia induces abdominal pain. This is like a vascular steal syndrome, where the blood flow from the superior mesenteric artery is diverted through collaterals to compensate the compression, and this causes small bowel ischemia and pain. This is the second theory. Then the third one is the neurological hypothesis. This is the most accepted now recently. This one says that overstimulation of the celiac plexus with subsequent splanchnic vasoconstriction and ischemia causes the pain. And the celiac plexus, I have already shown the picture branching between between the vertebrae, which is seen compressing along with this compression of the celiac artery. The histology of the celiac plexus nerves consists of pain fibers and inhibitory motor fibers to the stomach. So the entrapment of the ganglion and this plexus alter the gastric myoelectrical activity, and it impairs the antral motility. And this compression may induce pain, and compression also creates gastric dysmotility, nausea, and vomiting. So the rationale for MAL release rests on this theory that MAL syndrome results from compression of the celiac plexus. Now that is the pathophysiology. Now coming to the diagnosis. The pathophysiology is, there is little bit confusion regarding the pathophysiology, and so the diagnosis is also difficult in median arcuate ligament syndrome. The patient selection is very critically important for better results after any intervention. So first thing is history and physical examination. The history is usually they present with abdominal pain, and often it may be non-diagnostic or equivocal. And the history of previous surgical interventions can be collected, like cholecystectomy or diagnostic laparoscopy for the same abdominal pain. And there are some associations shown in some studies between median arcuate ligament syndrome and POTS autonomic neuropathy, that is postural orthostatic tachycardia syndrome, which is due to neural compression and reduced venous return also. And on physical examination, usually the patient will be, abdomen will be flat, thin, and non-tender abdomen, and there may not be an abdominal bruit. Usually it's not detected. And it is a female predilection. Female to male is 2:1 to 3:1, and usually detected in 4th to 5th decade, but it can vary for 2nd to 6th decade. Usually diagnosed very late after years of evaluation and all. Most patients have already done extensive workup done for abdominal pain, like ultrasound abdomen, endoscopy, colonoscopy, motility study, CT, MRI, everything. And these patients may be diagnosed sometimes as psychiatric or non-compliant or pain medication seeking behavior, etc. And one series suggests that 54% of these patients had undergone abdominal procedures for the pain, including cholecystectomy, exploratory laparotomy, or laparoscopy for any biliary or pancreatic procedures because of the pain. And the main signs and symptoms of medial arcuate ligament, I am giving it in this table. Like more common symptoms are, more common is the findings are the, it will be in 2nd to 6th decade of life, and female prediction 3:1. There will be postprandial abdominal pain, nausea, vomiting, unintentional weight loss, and exercise induced pain will be there. And the less common signs and symptoms are autonomic dysfunction, fibromyalgia, postural orthostatic tachycardia syndrome. So coming to the investigations, before coming to the investigation, I will just explain that normally during the expiration, the aorta moves in a cephalad upward direction and may subject the celiac artery and its surrounding celiac plexus to compress, to get compressed by the median arcuate ligament. And during inspiration, the celiac artery moves away from the median arcuate ligament, so as the aorta moves caudally. These distinct anatomic findings during normal breathing induce dynamic celiac artery velocities during inspiration and expiration. That is, there will be a change in velocity during inspiration and expiration in the celiac artery. So based on this, initially in 1960s and 1970s, there was the Pathonomic Test, and which is an invasive test, was the lateral iotography, and this was done in inspiratory and expiratory images, and it documents the presence and extent of the celiac artery compression, which the celiac artery compression can be seen in it, and the extent of the compression. So it's an invasive test, and nowadays it's not used because now the two most common diagnostic studies of medial arcuate ligaments are CT angiography and magnetic resonance angiography, which evaluate this. This can evaluate the structural elements of the celiac artery, aortic and celiac branch anatomy. Median arcuate ligament can be assessed, and the surrounding viscera, and identify any other concomitant abdominal disease and coexisting any neoplasms, mesenteric thrombosis, or atherosclerosis, etc. But the negative point is that it's not a dynamic study. That is, we can't evaluate in inspiration, or according to the respiratory cycle, we can't evaluate. So this picture is a lateral view which shows medial arcuate ligament compressing the celiac artery, and there is a post-stenotic dilatation of the celiac artery. So the other investigation is Iotic Angiography, which is a conventional angiography which may reveal an asymmetric focal narrowing of the proximal celiac axis with post-stenotic dilatation. And this can be this is the dynamic procedure. Narrowing is accentuated on expiration and relieved on inspiration, which can be seen. And the pressure gradient can also be measured. And increased collateral vessels in celiac artery distribution is also seen in this. So CT and MRI, as I said, it's not dynamic study, do not provide information during respiratory cycles. So some centers, they have started using some more similar transabdominal duplex ultrasound scanning of the celiac artery, which is used to diagnose median arcuate ligament syndrome. The transabdominal duplex ultrasound scanning is performed during inspiration and expiration by using a 3.5 to 5 megahertz probes, and ultrasound measurements focus on proximal portion of the celiac artery, that is just distal to its ostia. The proximal part is focused, and the criteria which is published by Moneta et al. Is a PSP greater than 200 centimeter per second, and no flow, and or retrograde common hepatic arterial flow during inspiration or expiration were consistent with a significant more than 70% stenosis of the celiac artery. A turbulent flow and an elevated PSP on expiration, which normalizes or decreases with inspiration and standing. That is, come back to normal on inspiration and standing, are suggestive of median arcuate ligament syndrome. So other ultrasound findings include abnormal origins of celiac and superior mesenteric arteries. Post-stenotic bulbar dilatation can be seen. Reversal of flow in hepatic artery. These are all identified in ultrasound. But the problem with the ultrasound is diagnostic ultrasound is technician dependent and requires a high degree of expertise to reliably assess the mesenteric vessels. Then the other investigation, this is not routinely done, but this is for gastric ischemia assessment, whether it is related to the celiac artery compression, which can be assessed. This is gastric exercise tonometry. So it is based on a relationship between increased carbon dioxide in mucosa and lumen of an ischemic bowel. This test uses arterial blood gases and nasogastric fluid, and it measures the arterial and gastric carbon dioxide levels before, during, and after 10 minutes of submaximal exercise. After acid suppression with a proton pump inhibitor or a H2 blocker, baseline measurement of the gastric PCO2 and arterial blood gases are obtained. Then a 10-minute bicycle test and a 20-minute recovery period. Blood gases and gastric PCO2 are measured during peak exercise and recovery. And the test results are: positive test is indicated by a gastric arterial PCO2 gradient greater than 0.8 kilopascal after exercise, an increase in gastric PCO2 from baseline to peak exercise, and an arterial lactate level less than 8 millimole per liter, all suggestive of gastric ischemia. So these are all the test investigations for medial arcuate ligament syndrome. Then coming to the management part, first one is the percutaneous celiac ganglion block. This can be done preoperatively, and some studies have done it preoperatively, that percutaneous celiac ganglion block, and after which that patients have shown very much symptomatic relief after the release. Those who had a better results with celiac ganglion block had better results with the surgery. So preoperatively done can be used as a diagnostic for MAS and potential therapeutic test also. But the data regarding this are limited. And the second thing is endovascular treatment. Endovascular treatment, PT alone does not benefit patients with malcompression of the celiac axis. That removal of compression is required. So PT and stenting can, the problem with it is it results in fractured stents and can cause early restenosis and also stent migration to visceral arteries. So PTA or stenting are now relatively contraindicated in the setting of median arcuate ligament syndrome, or not recommended. So the next one and the most widely used one is the laparoscopic technique, and most surgeons agree that laparoscopic diffusion of the median arcuate ligament and the associated celiac ganglion tissue also along with the median arcuate ligament are the critical for a successful treatment. So in addition to sympathetic pain fibers, the ganglion, I have already explained, it contains inhibitory sympathetic motor fibers, and it modulates the intrinsic neural circuit of the stomach. So decompressing or dividing the neural fibers would therefore decrease pain and improve the gastric motility and improve the symptoms like nausea, vomiting, etc. So this is mainly the laparoscopic port positions, and one port is placed higher up in the cephalad so that it can be directly, we can dissect the direct aorta easily. It will be over the epigastric region, one port, and the other port 5 mm ports and 10 ports. And what it's shown is that harmonic scalpel division of median arcuate ligament. So coming to the step of the laparoscopy technique, as standard 5-port laparoscopic technique with midline port placed slightly more cephalad to visualize the aortic and celiac artery, and harmonic ultrasonic scalpel is used to enter a lesser sac. After the liver is retracted and through a window in the hepatogastric ligament, it exposes the left gastric artery and the coronary vein, and these artery and vein are retracted from the left to right with a gentle traction. It shows an optimal view of the left and right borders of the aorta as it approaches the origin of the celiac artery. Now, an extensive dissection of common hepatic, left gastric, and splenic arteries are also performed. And typically, the dissection extends from 4 centimeter distal to the celiac artery bifurcation in order to divide all the neurovascular bundle surrounding the 3 associate vessels. That is, which is an important thing. And the crural and MAL fibers are then divided from the overlying aorta using a hook cautery. So the aortic dissection extends 5 cm proximal to the origin of the celiac artery to ensure complete division of the celiac plexus. The dissection extends to the prevertebral fascia on the right of the aorta and to the suspensory ligament of the fourth portion of the duodenum. All ganglionic fibers that are visualized are divided with the electrocautery or ultrasonic scalpel. So that is the laparoscopic technique. Coming to the open surgical treatment of median arcuate ligament syndrome, it is described by number of authors, and there are a lot of studies regarding open surgical and comparison of open with laparoscopic, but with few patient follow-ups and that I will discuss later. The open surgical technique is a decompression of median arcuate ligament with open celiac ganglionectomy or decompression with reconstruction bypass also. And studies showed the major complications following the open approaches. If we are bypassing with a graft, thrombus bypass graft, then cerebrovascular accidents in 1.4%, gastroesophageal reflux diseases are common after division of MAL, and pancreatitis, hemothorax, splenic infection. These are all the complications of open surgeries. Then coming to the few studies like that Harjola and Dunbar, which performed a midline laparotomy with decompression or division of MAL and the associated celiac plexus, and Rayleigh Elam et al. Reported 51 patients with 9 years of follow-up. In these patients, the combination of decompression alone, decompression with graduated celiac artery dilatation through a celiac or splenic arteriotomy, or decompression with reconstruction and bypass of the stenotic arteries. These 3 methods were followed. And of those 16 patients who underwent medial arcuate decompression alone, 56% patients achieved relief. Of the 35 patients who underwent decompression and reconstruction, 77% of the patients achieved symptom relief. So 25 patients who received post-op arteriogram, 10 of that 40% remained symptomatic even after the procedure, and 7 of those patients who remained symptomatic showed persistent celiac artery stenosis. That was the study result of Rayleigh. And coming to another study by Grotemier et al. He proposed a case series of 18 patients. 3 patients lost for follow-up already. 18 patients underwent open decompression, 11 of which had good results of their symptom. 5 of these 11 patients required additional interventions on celiac trunk prior to pain resolution. So several series have demonstrated successful laparoscopic treatment of median arcuate ligaments, and one is the Hayek et al. In a single center report including 14 patients, 38% of the patients were laparoscopic group, and 50% of the 13% of the laparoscopic group and 15% of the open group had persistent pain at the last follow-up. So what they concluded was there is a chance of late recurrence, and but the pain was milder than the initial presentation, and laparoscopy was associated with a shorter hospital stay and decreased time to feeding. This was the advantage of laparoscopy, which was mentioned over open surgery, where the shorter hospital stay and decreased time to feeding. The authors also concluded that optimal patient selection as a predictor of clinical response remains a challenge. And another retrospective study, which was published in 2012 with 20 studies, 13 studies reported open division and 7 studies reported laparoscopic division. 25% of the patients in the open series underwent concomitant arterial reconstruction also, along with the redivision. Laparoscopic group, 9% underwent celiac artery angioplasty and stenting after division of MAL. And the laparoscopic conversion to laparotomy was 9.1%. So intraoperative complication included visceral bleeding, pneumothorax, aortic bleeding, and phrenic arterial laceration in laparoscopic patient. All of these complications occurred at a rate of less than 4% only. So the follow-up of open group was done for 229 months and laparoscopy extended up to 44 months. So the authors finally documented immediate post-operative symptom relief in 85% of the patients, with a recurrence rate of 6.8% in the open group and 5.7% in the laparoscopic group. So these are about the laparoscopic and open studies. The another thing is a robotic assisted laparoscopic release. This was in few cases have been reported. Few studies are there in robotic assisted, but the only significant difference found between laparoscopy and robotic approach was a shorter operative time for laparoscopy. There is no clear advantage for a robotic assisted MAL release. Then the another approach is endoscopic retroperitoneal approach, and this was reported by Van Peterson et al. It was using he studied in 46 patients. Complication included 2% conversion rate to laparotomy pneumothorax in 4% of the patients, and 36 of the 46 postoperative angiography confirmed normal vessel anatomy. 6 out of the remaining 10 underwent endovascular treatment along with it had a successful dilatation with resolution of the celiac artery stenosis. And the symptoms were based on 3 responses: free of symptoms, improved or persistent symptoms during the follow-up. So 41 out of 46 patients reported improvement of symptoms in endoscopic retroperitoneal approach. But those who had persistent symptom, they doesn't require any intervention for the arterial compression, like endovascular intervention. So what they are referring is that further this report suggested that MAL is a neurogenic disease only, and the vascular abnormalities are only a physiological marker for the ligamentous compression on the artery and nerve plexus. So their median follow-up was 20 months. It is comparable to the open procedure. The Kim and et al. He proposed, finally, after all the evaluating the studies and his institutional evaluation, he proposed an algorithm for the diagnosis and evaluation and intervention of MALS patient. And this is like workup for the abdominal pain, including the right upper quadrant pain initially with ultrasound, CT, endoscopy, or HIDA scan or anything, and abnormal findings in these workup results the treatment for that pathology. And if all these workups are normal in these studies, this lead to a duplex ultrasound of the celiac artery. And after that, findings suggestive of MAL, medial arcuate ligament syndrome, or equivocal ultrasound findings, they need a CT angio or MRA or angiography of the celiac artery with pressure gradient measurements for the confirmation of the MALS. And evidence of celiac artery compression is an indication for laparoscopic or robotic MAL release with celiac ganglionectomy. Follow-up included post-operative celiac artery duplex ultrasound and assessment of the symptom resolution. If symptom persist, angiography of the celiac artery with pressure gradient measurement is used to diagnose any residual stenosis. And if stenosis remains, angioplasty or stenting of the celiac artery is recommended. If symptoms still persist, vascular reconstruction should be considered if ischemia is felt to contribute to the patient's pain. So this is an algorithm for the workup of median arcuate ligament syndrome patients. So to conclude, it is a difficult disease to diagnose, and recently there is increasing incidence of surgical treatment for this apparently rare disease. Vascular abnormalities are usually only a physiological markers, and celiac compression and celiac compression dynamic ultrasound velocities. True pathophysiology is the celiac plus neural compression. And case series, all the case series available are with small number of patients and follow less than 3 years. And it is important that a subjective and objective data are collected before treating a patient to make an algorithm to identify who is benefited from a surgical intervention. That's also. Thank you, sir.